Mehta coming us from Singapore, of course, who will be speaking on presbyopia management in eyes with irregular corneas.
Great, thank you, Tony. Great. So good morning, everyone. So thank you for coming to the session. So I want to thank the Cornea Society for this kind invitation to talk in the symposium. So I'll be talking about presbyopic management in eyes with irregular corneas. These are my disclosures. It's probably pertaining to BNL, who've now taken over this lens itself. So of course, we know there's an increased desire for patients to be spectacle independent, so many of us use multifocal intraocular lenses implantation, but they can be associated with certain problems such as phototic phenomena, fixed focal changes, and of course, these are really not suitable in eyes with basically aberrated corneas, and I think most of us will probably feel that in complex corneas, i.e. those who've had previous corneal refractive surgery or corneal scars, we certainly probably wouldn't put a multifocal IOL in. Of course, the range of dysphotopsia with different multifocal lenses varies. I mean, my go-to lens now is a refractive multifocal lens, but even in the refractive lenses, if you put them in these post-cap LASIK patients, you'll see they do have higher rates of basic glare and halos. And of course, in most diffractive multifocal lenses, of course, these levels are basically much higher anyway. So of course, monovision is an option to basically fix this, but the problem with monovision is that basically you're going to have a fixed focal length either at near or basically intermediate vision. Amma basically describes his pinhole pupiloplasty as a technique to basically reduce aberrations, but of course when you do that, there's no basically view of the retina itself. And we have to bear in mind that biometry accuracy is obviously less in these eyes with basically aberrated corneas. And I just want to illustrate this from basically these defocus curves. So if you look at this defocus curve for one eye that's basically been set for far, and then you look at one eye that's basically set for intermediate or basically near vision, what you have is this sort of valley of depth between the far and near vision. And patients say, well, I can see far, and somewhere they lose it a little bit, and then they can basically see near. And this is what probably I was doing maybe about 6 or 7 years ago for most of my patients when they used to come to try to give them some level of near reading vision after they had post-refractive surgery. So of course we need an alternative lens that can basically bridge this gap between in this valley of depth. And the ICA, basically, which is a small aperture implant, was basically developed for this. It gives you a continuous depth of focus with a tolerance up to about 1.5 diopters of astigmatism. You can basically reduce the effect of high-word aberrations, which is great because I think this is what I use for a lot of my post-refractive patients. Recently, it was approved in the FDA, and we were part of the FDA's data that was used to basically get FDA approval. And I've been using this lens for about 7 years, so I have quite a reasonable experience with this lens as well. This is the principle of the lens. Basically, it's quite simple. It has a mask on the central part of a hydrophobic lens. So it basically will only look at the light rays from the central 1.3 millimeters, and the rays around there are basically masked from the surface. And if you compare the defocus curves in normal eyes, you will see that you get a basically shift of about 2 diopters of extended depth of focus from a standard basically monofocal. The other big advantage of the lens is when you look at MTF function for the quality of the vision measured on the retinal surface, you'll see you have a far better quality of vision of this lens compared to any of the diffractive EDOF lenses or even the non-diffractive EDOF lenses, because of course you get better light transmission because at the end of the day, the central 1.3 millimeters is a standard monofocal hydrophobic lens. When you look at basically the effectiveness of the lens itself with respect to distance and intermediate vision, looking at the monocular eye itself, the lens works best if you basically aim for a biometry between 0.5 to basically -1 diopter. And what I could typically choose is if a slightly older patient, I sort of err on the side of caution on about 0.75, -0.75. If it's slightly younger, I basically go on a 0.5 diopter. But remember, this is monocular. But when you see this binocular, patients obviously get very good visual acuity because you have the distance vision from basically the dominant eye. The insertion of the lens is quite straightforward. I do this with flax, and I'll show you a reason why, but actually you can do this with a normal manual well-centered rexus. There's no need to use a femtosecond laser. And in our study, we basically looked at the effects basically in aberrated corneas, and these were basically primary aberrated corneas, such as cases with basically keratoconus, which I think this works really well in, or it can basically be secondary aberrations related to post-refractive surgery, ectasia or corneal scars, or basically related to any corneal refractive basically surgery. So once the phaco is done in the normal manner, I'll just skip this for the interest of time. The lens insertion is quite straightforward. The lens does come in a cartridge. It comes in a 3.2 millimeter cartridge, which I actually never use, which is provided by the company. And all I use an SA60 cartridge, or you can use a J&J cartridge instead. And the lens actually fits in quite comfortably into those cartridges as well. And it will allow you to put it through a 2.6 millimeter incision. You need to be a little bit careful when you take the lens out of the hole. It's quite sticky sometimes and stuff. So I normally go there at the optic haptic junction. So the lens itself basically just folded into the cartridge. Normally you don't have any issues with the cartridge. You can use a B or basically a C cartridge. Obviously, if you're using a slightly more higher power lens, the lens goes up to 30 diopter power currently at the moment. and the size of the mask is actually fixed, but this may change in the future since B&L now taken over the company, and they plan to make different options with respect to the mask sizing. So it's 1.3 millimeters in the middle and a 3.6 millimeter mask basically around the surface. So these are some of the cases I use the lens in. This is a patient, 75-year-old lady, who's a dentist from Malaysia. You can see that she had previous hyperopic LASIK, so high levels of vertical and horizontal coma, but of course low levels of spherical aberration basically in both eyes. The right eye is basically dominant. So the right eye gets a monofocal lens, and I use an SA60 to balance the spherical aberration. The left eye basically put an IC8 in, and she gets pretty reasonable intermediate vision and near vision, so she's reading N5. But the best thing about this lens is they actually get much better distance vision in the eye than you would actually expect. So she's actually 6'9", unaided for distance, and overall she's got very good distance intermediate and basically near vision. The opposite of that basically is the LASIK, post-LASIK correction. So this is a guy who had LASIK 10 years ago. Right eye is dominant, so he's got slightly higher levels of spherical aberration in both eyes that you can see in the right and the left eye. The right eye I put a monofocal lens now to reduce the spherical aberration, so I use a ZC-BOO lens. The left eye basically put an ICA, and again, much better unaided distance vision than you'd expect, but good intermediate and near vision, and binocularly very happy with 6.7.5. These are some of the other cases I've used them in: corneal scars, so again, high levels of spherical aberration and vertical coma. The left eye basically underwent flax. The right eye was basically still faking, so binocularly he's very good with N6 intermediate and near, and 6.6 basically unaided basically for distance. Patients with RK, it works really well, and I still only put it in basically one eye. We can discuss that a little bit at the end. And again, good unaided vision for distance, but also very good intermediate and near vision. And RK, you know, the whole surface is very aberrated, and I think this is a great lens choice to basically put this in. Other cases, including intracore as well, which ironically was also made by B&L, and you can get secondary ectasias. You can see the scarring there basically on the surface. So the aberrations are very irregular on the surface. And again, the right eye, which is the dominant eye, I put a ZC-BOO, and the left eye, I used this lens to give very good intermediate and near vision and best corrected vision as well. So if you look at the defocus curves, the differences, and this is one of the patients from the study, you'll see the right eye now basically you bang on target because obviously it's your dominant eye. The left eye is the eye basically that has the IC8 in. And what you're doing is when you're looking binocularly, you basically bridge that gap, so you don't get that value of depth that you see basically if you go for standard basically monovision. If you look in our series that was basically published at JRS, you'll see most of the cases either post-refractive surgery, which is the cases where I really use a lot of this lens in, and keratoconus. And if you look at the IC8 eye with respect to the fellow eye, of course, the unaided distance vision is slightly worse, but you have better intermediate and also near vision. But it's also important to look at the binocular vision, and you can see excellent binocular vision unaided for distance intermediate and near. Likewise, when you look at the spherical equivalent, you'll see that the ICA eye is slightly more myopic compared to basically the fellow eye. In our paper, we looked at centration values, and that's why I basically use flax. But to be frank, as long as you've got a well-centered rexus, you can just do this manually as well. You don't need to use a femtosecond laser, but you can show from the results that you get very little displacement intraoperatively versus basically postoperatively. When you look at the defocus curves, again, it shows you the same thing from the whole series of patients. Again, you see that effect regardless of the pathology. And when you look at contrast sensitivity, you'll see that, of course, there is a reduction in contrast sensitivity in the eye that has the mask, but binocularly, the patients actually see very well overall, and the function is basically taken from the dominant eye, not the eye that basically has the ICA. So in conclusion, the combination of small aperture optics enabled improvement in near, intermediate, and basic distance vision. Complications in the series, we didn't have any, but I have had to do one lens exchange for a patient who just really couldn't adapt to the reduction in the contrast in her eye. We've had no issues with the procedure. The lens is very easy to insert, but you have to remember about treating the ocular surface after this procedure as well, because of course many of these patients have very irregular corneas, and of course the refractive change in the ocular surface is going to affect the total refractive outcome. Just a few tips: if you do use in younger patients, you may need to give them pilocarpine because sometimes the pupil dilator will go beyond the area of the mask, and they'll get issues with glare and halos. Some of my patients, if they're younger, they do use this once or twice a week to basically bring the pupil down. I don't do bilateral implantation. Bobby does have a paper on this because of really a reduction in the contrast. You need to be careful with your centration, especially if you're doing it at high levels of keratoconus as well, and patients with large angle cappas. And if the patients have had ectasia previously and they're cross-linked and they develop haze, you need to be careful, because if the lens centers where the haze is, it will definitely affect the visual acuity. I do YAG them early, but you have to be careful when you do YAG. I go around the mask, and like in the picture on the right-hand side, if they do move and you do hit the mask, you will basically decolorize the mask itself. It doesn't seem to affect the visual quality. It just doesn't look very good as well. And I do combine it like with Tony's case, with DMEC as well, because it allows you to give a slightly larger landing pad, especially if the patients want to have some intermediate and near vision. Thank you for your attention.
Are there any questions from the audience? I don't personally have experience with IC8, but I had a patient recently, Judd, who was post-RK patient with cataract and was asking my colleagues about IOL formulas, et cetera, and one of them said that this is their go-to lens in patients post-RK.
Yeah.
Can you comment, is that the case for you? And if not, what criteria do you go by to decide in a post-RK patient whether this would be the right lens for them?
Yeah, so it is my go-to lens, but the decision that is made is that which eye do you put the lens in, because currently at the moment the masks are the same size. So what I do is that I will look at the basically topography and see which eye has got the more irregular cornea, and that's the eye I basically go for. I basically put the IC8 in, and then the other eye I just actually use a monofocal in itself, and that seems to basically work quite well. But because you've got that depth of focus with the pinhole optics, it allows you to be a little bit more, gives you a little bit more leeway with the accurate and the barmetry form, because that can be obviously very challenging, especially as we mentioned in the regular corneas, to actually calculate an accurate barmetry.
And if the patient is wearing contact lens or not, does that factor in any way in terms of whether you consider this lens and if you still put it in the eye with a greater corneal irregularity?
Yeah, so most of the RK patients, if they're unaided, then of course, there's not an issue. If they're wearing contact lens, and so if it's a keratoconic, for example, they're wearing basically a contact lens, then I'm slightly more different in that way. If they want more depth of focus, then I will still basically put an IC8, but I'll be much more accurate with the barmetry, because I can aim for slightly more myopic outcome and stuff as well.
Okay. Are there any other